Assalamualaikum and hello to everyone. In this video, we will talking about pitfall in thyroid cytopathology. Without further ado, let's take a quick recap of benign and normal cytomorphology of thyroid, which are include small monolayer and honeycomb sheets, evenly distributed follicular cells with colloid background. Benign thyroid includes colloid goiter, hyperplastic nodules, thyroid cysts, autoimmune thyroiditis, which are Hashimoto and Graft disease. For malignant, thyroids includes papillary carcinoma, medullary carcinoma, anaplastic carcinoma, and other malignancies such lymphoma and metastatic tumor. Pitfall refers to where cytologic features are referred to false positive or false negative. False positive are referred to where benign cells are misinterpreted as malignant, while for false negative are when malignant cells are considered as benign. However, false positive also can be occur when malignant cells are classified to wrong types of malignancy.
Assalamualaikum. Hi, my name is Sarah. I will proceed with benign cystic lesions. Cystic or mainly cystic thyroid nodules are observed in around 15 to 25% of thyroid lesions, with the majority being histologically benign. FNA of these can sometimes mimic PTC, especially when there is nuclear epithelium. So, what is the microscopic finding in the benign cystic lesions? The first one, foamy and hemosiderin laden macrophages, scan colloid, and few follicular cells. Next is benign cystic lesions, a pitfall mimicking PTC. From this research paper, the figure shows papinocolostain, which has nuclear atypia under FNA, where it consists of scan colloid, grooves, and nuclear enlargement. It can mimic PTC due to grooves. So, what is the characteristic of PTC that can differentiate from benign cystic changes is intranuclear plasmid invagination, panuclei, grooves, and powdery chromatin. Please take note of intranuclear cytoplasmic invagination as it can differentiate PTC from benign cystic lesions. I think that's all for me. Thank you.
On this slide, I would like to highlight an important diagnostic pitfall in thyroid cytology, which is lymphocytic thyroiditis, also known as Hashimoto thyroiditis, and how it can mimic papillary thyroid carcinoma or PTC on FNAC. Lymphocytic thyroiditis is a chronic autoimmune inflammatory condition. Because of this inflammation, the follicular cells undergo reactive nuclear and cellular changes. These changes can look very similar to malignant features, especially those seen in PTC. On the left side, we can see features of lymphocytic thyroiditis. The nuclei are slightly enlarged and nuclear groove may be present, but the nuclear membrane is irregular and not sharply defined. Importantly, we can also see lymphocytes in the background and infiltrating the follicular cells, which support a benign inflammatory process. On the right side, this shows papillary thyroid carcinoma. Here, the nuclei are more markedly enlarged, the nuclear grooves are frequent, and the nuclear membranes are irregular but well defined and sharp. In contrast to thyroiditis, lymphocytes are usually absent, and the nuclear features are more uniform and malignant in appearance. Therefore, the key pitfall is that inflammation in lymphocytic thyroiditis can produce PTC-like nuclear changes, leading to potential overdiagnosis. This slide demonstrates another important pitfall in thyroid cytology, where lymphocytic thyroiditis can mimic lymphoma on FNAC. In lymphocytic thyroiditis, the thyroid gland is heavily infiltrated by lymphocytes due to autoimmune destruction. As a result, the smear appears predominantly lymphoid, which may falsely suggest a primary thyroid lymphoma. On the left, in lymphocytic thyroiditis, we see a mixed population of small and large lymphocytes with fine chromatin and relatively smooth, only slightly irregular nuclear membranes. Residual thyroid epithelial cells may still be present. On the right, in lymphoma, the smear shows monotonous sheet of atypical lymphoid cells with coarse chromatin and more irregular nuclear membranes, and thyroid epithelial cells are usually absent. Therefore, the key pitfall is that reactive lymphoid infiltrate in lymphocytic thyroiditis can simulate lymphoma, and careful assessment of cell population and nuclear features is essential to avoid misdiagnosis.
Hashimoto thyroiditis is possible in mimicking Hurter cell neoplasm. Firstly, Hurter cell is actually a metaplastic condition of follicular cells that undergoes oncocytic changes due to mitochondrial proliferations. Thi- These pitfalls occur due to Hashimoto disease are often shown abundant Hurter cell which can resemble neoplastic process. Hashimoto disease are likely to have a numerous or mix of inflammatory cells like lymphocytes. By comparing two hotel cell neoplasm features, the background appearance are likely to be clean with monotonous uniform hotel cells. These two distinct features are able to help better diagnosis to differentiate between hotel cell neoplasm and lymphocytic thyroiditis of Hashimoto disease.
Next, I will continue with the Graves' disease, a pitfall mimicking papillary thyroid carcinoma. Graves' disease is a benign autoimmune thyroid disorder and one of the most common causes of hyperthyroidism. Patients with Graves' disease frequently have thyroid nodules, which often leads to fine needle aspiration for cytologic evaluation. Therefore, although the overall risk of malignancy in this nodule is low, range from 1.9 until 2.5%, Graves' disease represents an important diagnostic pitfall. This is because the cytologic changes seen in Graves' disease, particularly after radioactive iodine therapy, can closely mimic the nuclear features of papillary thyroid carcinoma. Next, as demonstrated in this image, Graves' disease shows reactive cytologic changes including follicular cell pleomorphism, nuclear enlargement, firefly cytoplasms, and a lymphocytic background. These findings may appear atypical, however, they are nonspecific and reactive, and do not represent true malignancy. If these features are overinterpreted, they may lead to a false positive diagnosis of papillary thyroid carcinoma. In this slide also highlights how Graves' disease can be mistaken for papillary thyroid carcinoma and how the distinction can be made. On the Graves' disease slide, the cells show incomplete and non-specific nuclear atypia. Although nuclear enlargement and pleomorphisms are present, classic diagnostic nuclear features of papillary thyroid carcinoma are absent. In contrast, papillary thyroid carcinoma demonstrate well-developed and reproduced nuclear features, including powdery chromatin, nuclear growth, and intranuclear cytoplasmic pseudo-inclusions, as shown here. So, the Graves' disease mimic papillary thyroid carcinoma through reactive nuclear atypia. However, papillary thyroid carcinoma should only be diagnosed when a requirement of classic nuclear features is present, together with appropriate clinical correlation in order to avoid false positive diagnosis and unnecessary treatment.
In this slide, it is a picture that demonstrates the classic cytopathological features of medullary thyroid carcinoma in a pap stain. The characteristics includes loosely cohesive clusters or in singles cell arrangement, eccentrically located nucleus with moderate, finely granulated cytoplasm. It has an inconspicuous nucleoli and salt and pepper chromatin appearance, which is stippled chromatin. In this slide, it shows one of the pitfalls for MTC, which is oncocytic Hurter cell neoplasm. According to our journal reference by Rossi et al. 2019, MTC is frequently misclassified as Hurter cell neoplasm for its granular cytoplasm and tendency to appear in discohesive clusters. Some overlapping features between both includes eccentric nucleus, loose clusters, and granular cytoplasm that often leads to false negative diagnosis of MTC. To avoid this pitfall, we should also observe other features such as the presence of nucleoli and the color of granules in both cytoplasm. To compare these two pictures, in MGG stain, MTC have a less dense granular cytoplasm that is pinkish red in color, while Hurter cell neoplasm have a more dense granular cytoplasm that is more bluish violet in color.
MTC have inconspicuous nucleoli, while Herter cell neoplasm have prominent nucleoli. Next, this slide shows another example of pitfall for MTC, which is papillary thyroid carcinoma. So let's recap the classic features of PTC. It includes nuclear grooves, intranuclear inclusions, powdery chromatin or hypochromatic nucleus, usually in monolayer sheets or sometimes in loosely cohesive clusters. MTC becomes a pitfall for PTC due to its tendency to have overlapping features similar to PTC, which is the intranuclear inclusions that could lead to confusion in diagnosis. However, we should remember that MTC lacks nuclear grooves. It has salt and pepper chromatin pattern that does not commonly associated with PTC characteristics. We should not only look at one distinct feature to diagnose carcinoma in thyroid cytopathology because it may appear in other cases too, which adds to the confusion and potential of mixed diagnosis, whether it is false negative or false positive.
Hello everyone, I am Mohammed Shamuddin. We now come to poorly differentiated thyroid carcinoma or PDC. PDC is defined as a malignant epithelial neoplasm arising from thyroid follicular cells. It occupies an intermediate position between well-differentiated carcinomas like papillary or follicular thyroid carcinoma and the highly aggressive anaplastic thyroid carcinoma. Importantly, PDC can be a major diagnostic pitfall in FNA cytology due to its non-specific cytomorphology, which overlaps significantly with several other thyroid lesions. Let's review the classic cytological features of PDC. First, the smears are typically hypercellular with a monotonous population of cells arranged in trabecular and insular groups. The cells themselves are small to medium in size with a high NC ratio. Their cytoplasm is usually scanty and pale. Nuclei are round with coarse chromatin and often show small but distinct nucleoli. Finally, the background is generally clean, but necrosis may be present, which can be a clue toward its high-grade nature. Now let's review the key cytopathologic mimics of PDC. The first and perhaps most common mimic is follicular neoplasm. PDC shares with it a trabecular architecture and a monotonous cytology which can lead to misclassification, especially in limited samples. Second, Hertel cell neoplasm can mimic PDC when there is oncocytic cytoplasmic metaplasia present in PDC cases. The granular abundant cytoplasm of Hertel cells can sometimes be confused with the pale scan cytoplasm of PDC if not carefully evaluated. Third, medullary thyroid carcinoma is a significant mimic due to overlapping insular cytomorphology. Both can show rounded nuclei and similar architectural pattern. Helpful discriminator for medullary carcinoma include amyloid in the background and positive immunohistochemical stains for calcitonin, which are absent in PDC. Lastly, metastatic carcinoma to the thyroid and can closely resemble PDC because both often present as high-grade monotonous epithelial proliferations. Clinical history and immunohistochemistry are essential to avoid this pitfall. Next, we continue on pitfall for PDC. For instance, the prominence of microfollicles, as highlighted here, can instantly pull your diagnostic mind toward a follicular neoplasm. This is a classic trap because PDC can sometimes present with microfollicular structures, overshadowing its more characteristic insular and trabecular patterns. Similarly, the slide reference medullary thyroid carcinoma, as noted, both tumors can exhibit overlapping features. Without immunohistochemistry for calcitonin, this overlap is a significant pitfall. That is all from me. I will pass it to the next presenter.
Anaplastic thyroid carcinoma is a rare but extremely aggressive form of thyroid cancer. Although uncommon, it is one of the most lethal endocrine malignancies. From a cytological perspective, ATC is usually easy to recognize as a high-grade malignancy. Finding the aspiration typically shows markedly pleomorphic tumor cells which may appear as hepatocyte, spindle-shaped, and giant cells, often accompanied by the necrosis and high mitotic activity. However, despite its aggressive appearance, ATC presents an important diagnostic challenge because it lacks features of a normal thyroid differentiation. Immunohistochemically, most anaplastic thyroid carcinomas are negative for thyroglobulin and TTF1, which helps distinguish them from differentiated thyroid cancers. One of the most significant diagnostic pitfalls is differentiating ATC from a metastatic tumors to the thyroid. Although metastases to the thyroid are rare, they do occur actually, most commonly from a lung carcinoma, renal cell carcinoma, melanoma, and squamous cell carcinoma. Cytologically, these metastatic tumors can closely resemble ATC because they are also present as a high-grade, poorly differentiated malignancies. First, looking at the image which is stained with Papa Nicolau stain at a high magnifications. Most of the cells seen here are normal thyroid follicular cells, which may appear blue to purple and form small clusters. This represents a non-cancerous background of the thyroid tissue. However, scattered among these normal cells are abnormal cells. These cells poorly cohesive, meaning that they appear individually rather than in clusters. They also show enlarged and irregular nuclei with prominent nuclei, which are features of malignancies. Some of these abnormal cells contain brown pigment, which is melanin, suggesting a melanocytic origin. This pattern is unusual for primary thyroid cancer and raises suspicion of metastatic disease. Next, an immunohistochemical stain called a melan A is used. Melan A is a specific marker for melanoma. In this image, the tumor cells stain positive, appearing dark, while the normal thyroid follicle cells remain negative. Therefore, clinical history is crucial, especially a known history of extrathyroidal malignancy. Immunohistochemistry play a key role in confirming the tumor origin and preventing misdiagnosis.
Lastly, conclusion. So, in conclusion, because of the potential pitfalls in evaluating thyroid fine needle aspiration specimens, careful attention to both cytologic findings and relevant clinical features is essential. The appropriate use of immunohistochemistry, IHC, and other ancillary studies can further minimize diagnostic errors, enhance interpretive accuracy, and support more confident classification of challenging cases. Ultimately, this integrated approach contributes to more precise diagnosis, better clinical decision making, and improved patient care. I think that's all. Thank you.